Bismillahirrahmanirrahim. Let's start with the quote of the day. It takes a good fall to really know where you stand. Haley Williams. The topic of my presentation today is diphtheria. I'll be presenting under the kind supervision of my kind professor, supervisor Professor Dr. Saira Afzal. Learning outlines, introduction of diphtheria, epidemiological triad, chain of transmission, clinical types, levels of prevention, recent advances, MCQs. Learning outcomes would be, by the end of the presentation, participants will be able to describe about diphtheria, mode of prevention, treatment, recent update, and MCQs. Introduction. Diphtheria is a bacterial infection caused by Corynebacterium diphtheria transmitted from person to person through close physical and respiratory contact. It can cause infection of the respiratory tract, throat, nose, larynx, local production of false membrane with the release of exotoxins, which may lead to breathing difficulties and death. Occurrence. Prevalence throughout the world occurs in temperate zone. Epidemics are usually local and not widespread. In countries where effective primary immunization practice, it has become rare. Corynebacterium diphtheria. Klebsiella. Corynebacterium diphtheria agent is the Corynebacterium diphtheria or the Klebsiella bacillus. It is gram-positive club-shaped, comparing Chinese letter L and V. There are 4 types: gravis, mitis, intermedius, and minimus. Host. Children of 1 to 5 years of age, both sexes, low socioeconomic status. Infants are immune till 6 months of age because of maternal antibodies. Environment, mostly during winter and autumn, and overcrowding. Chain of transmission, reservoir, infected person, case or carrier. Source of infection, nasopharyngeal secretions, discharge from skin lesions, contaminated fomites, infected dust. Mode of transmission also includes the direct and the indirect. By infected cutaneous lesions and droplet infection, and the indirect has fomite-borne. Portal of entry, respiratory route, non-respiratory route, cuts, wounds, ulcers, umbilicus in newborn. Periods of communicability, 14 to 28 days from the onset of disease. Carriers may have much longer time. Incubation period includes 2 to 6 days. Pathogenesis. Bacteria multiplies in throat and releases powerful exotoxin, which is responsible for formation of grayish or yellow membrane, false pseudomembrane all over tonsil, pharynx, and larynx, with well-defined edges and can be wiped away. Second, marked congestion, edema, and local tissue destruction. Third includes the enlargement of regional lymph nodes, and then there would be signs and symptoms of toxemia. Here is a picture depicting the diphtheria. The remote effects of diphtheria toxin has heart, kidney, liver, adrenals, and peripheral nerves involved. Diphtheria antitoxin may neutralize the circulating toxin, but ineffective once cell penetration has occurred. The clinical types are, the first one is the pharyngeal diphtheria. Early manifestations are mild sore throat, fever, and malaise, membrane formation, stridor, dysphagia, enlarged cervical lymph nodes, producing a bull neck, toxic look. The second one, laryngeal diphtheria, usually associated with pharyngeal diphtheria, may be primary or without membrane, hoarseness, cough, stridor, and restlessness, cyanosis. Death usually occurs due to suffocation. Nasal diphtheria, chronic serous or seropudent discharge, crusty, exudated around the nose, foul odor, white membrane on the nasal membrane. The cutaneous diphtheria is the 4th type. It is also called the desert sore, chronic tropical ulcer, punched out ulcer, uncommon. 5th one is the ocular diphtheria, then 6th one is the vaginal diphtheria, and there are some rare types included. The complications are respiratory failure, occlusion of airway by membrane. Second one is the acute toxic myocarditis can leading to the CHF, arrhythmias, and sudden death. Third one is the neurological, which may include the parietal palsy, ocular palsy, and the polyneuritis. And the 4th are the renal complications. The primary prevention of disease is by ensuring high population immunity through immunization. Specific protection. The diphtheria toxide. The toxide drawn in liquid medium from toxigenic C. diphtheria, available in combination with pertussis and tetanus vaccine, gives clinical efficacy of 97%. Allergy to toxicoid or any component of vaccine is a Contraindication for administration, local reaction like erythema is common, should be stored at 2 to 8 degrees Celsius. Frozen vaccine should never be administered. Primary vaccination. The the primary vaccination schedule is here. The primary one has age 2 months, and the first one is the dose primary one. Age would be 2 months and interval known. Dose primary 2, age 4 months, interval 4 weeks. Dose primary 3, age 6 months, interval 4 weeks. Dose primary 4 includes age 15 to 18 months and interval 6 months. DTaP, diphtheria, tetanus toxoid, and acellular pertussis vaccine is a vaccine of choice for children 6 weeks through 6 years of age. If child has valid contraindications to pertussis vaccine, then pediatric DT should be used to complete the vaccination series. If the 4 doses of DT, DTP, or DTaP are administered before the 4th birthday, a booster 5th dose is recommended at 4 through 6 years of age. Here is a pictorial representation of the childhood immunization schedule for diphtheria, tetanus, and acellular pertussis vaccine. If child has the tetanus, diphtheria, and the pertussis booster doses, 4 to 6 years of age before entering school, DTaP, 11 to 12 years of age, TDAP. It is a booster immunization given at age 11, every 10 years thereafter, TD, and it protects the adults. So the motto is the people of all ages need diphtheria vaccines. Here is the API schedule, and you can see diphtheria, the causative agent. The vaccine is the pentavalent vaccine, DTP, Hep B, and the HIV, and doses are 3. And the age of administration is 6 weeks, 10 weeks, and 14 weeks. Secondary prevention. It includes the secondary prevention of spread by the rapid investigation of close contacts to ensure their proper treatment. Diagnosis mainly would be clinical. Simple throat smear should be examined. If diphtheria-like organisms, culture should be obtained. Administration of antitoxin without waiting culture report. Schick test. Immunity to diphtheria can be determined by the Schick test, useful for detecting persons at high risk, such as physicians, nurses, and hospital staff. Intradermal test depends on fact that toxin exert local destructive or irritating actions on tissues. 0.2 ml of Schick test toxin is injected into the skin of forearm as test, while 0.2 ml of inactivated toxin is injected on the other forearm as control. Interpretation of results: positive reaction, circumscribed area of redness up to 3 centimeters or more in diameter within 24 to 36 hours, and maximum by 4th to 7th day on test arm, and control arm has no change susceptible to diphtheria. Second, the negative reaction, both arms are without reaction, person is immune. Third is a pseudo-positive reaction, red flush appears on both arms but fades within 4 days. Allergic type of reaction, Schick negative. Fourth one is the combined reaction, true arm shows true positive and control arm shows pseudo-positive susceptible to diphtheria. The control and the treatment, it includes early detection of cases and carriers, isolation, and then the treatment. Control of patients, first we have to do is the notification to local health authorities. Second, isolation imposed unless two consecutive cultures from the throat and 2 from nose 24 hours apart fail to show virulent diphtheria bacilli. Cases, diphtheria antitoxin should be given without delay intramuscular after given 0.2 ml subcutaneous as a test dose. In the mild cases, 40,000 units would be given. In the moderate cases, 80,000 units would be given. And in the severe cases, 120,000 units would be given. Then the benzyl penicillin in 2.5 lakh units every 6 hourly, or erythromycin 250 mg every 6 hourly for 5 to 6 days. Carriers, erythromycin 250 mg every 6 hours for 10 days would be given. Contacts, if primary immunization or booster within previous 2 years, no further infection. If a primary immunization or booster dose of DT more than 2 years before only booster dose of DT. Third is a non-immunization close contact should receive prophylactic penicillin or erythromycin with 1,000 to 2,000 units of diphtheria antitoxin and actively immunized against diphtheria. Number 4, contact should be examined daily for 7 days for any evidence of diphtheria. Community, active immunization with diphtheria of all infants with subsequent booster doses every 10 years thereafter. Institutional control. In case of diphtheria breakout, in closed community like boarding houses, orphanages, juvenile jails, schools, and hospitals, etc., the whole community should be actively and passively immunized with refined intoxin in one arm, 1,000 to 1,500 ml units for adults and 750,000 units for children, intramuscular, and 0.5 cc of APT, alum precipitate toxide in the opposite arm subcutaneous at the earliest opportunity. The entire toxin provides temporary protection lasting about 2 to 3 weeks. After 2 weeks, a second dose of 0.5 cc of APT should be given. After this, take throat swabs of the entire population and segregate all throat swab positive virulent carriers for 15 days, because this is the time when passive immunity, which lasts only for 15 days, fades away and active immunization start developing. After this period of 15 days of segregation, the active immunity will rise sufficiently to protect the inoculated persons from the risk of infection. The tertiary prevention of complications and deaths by early diagnosis and proper management would be done. Now, time for the recent updates. The WHO recommended surveillance standard of diphtheria. The rationale for surveillance is basically the control of diphtheria is based on the following three measures: the primary prevention of disease by ensuring high population immunity through immunization, and then there is second one, that is the secondary prevention of spread by the rapid investigation of close contacts to ensure the proper treatment. Then there is the third, the tertiary prevention of complications and deaths by early diagnosis and proper management. Surveillance data can be used to monitor levels of coverage. So the recommended case definition is also given, and the lab criteria for diagnosis is basically the isolation of the diphtheria from a clinical specimen or fourfold or greater rise in serum antibody. Epidemiological update, diphtheria. Summary, the situation summary in the Americas is in 2021 between epidemiological week 1 and 2. 4 countries report confirmed case of diphtheria: Brazil that with 1 case, Colombia with 1 fatal case, Haiti with 18 cases, including 3 deaths, and the Dominican Republic with 18 cases, including 12 deaths. So what is the true burden of diphtheria, tetanus, pertussis, and poliovirus in children aged 3 to 18 years in Asia? Systematic literature review. The conclusion told us the true burden of diphtheria, pertussis, and tetanus in children aged 3 to 18 years in Asia is unknown because of weak or absent nationwide surveillance systems. The available evidence highlights the inadequacy in immunity, either by gaps in the recommendation or suboptimal booster coverage, supporting the public health need for the booster vaccination in this population. Now, time for the multiple choice questions. XYZ patient admitted in the hospital with the susceptible suspicion of diphtheria, and proper isolation is also done, but the incubation period of the disease passed and there is chances of spread for close contacts. What is the recommendation of immunization for close contacts? A, if primary immunization or booster within 2 years, no further action. If primary immunization or booster within 3 years, no further action. C, if primary immunization or booster within 4 years, no further action. D, if primary immunization or booster within 5 years, no further action. And E includes if the primary immunization or booster within 6 years, no further action. So which one would be correct?
A.
Yes, A. It's the primary immunization or booster within 2 years, as earlier told. Then the question 2. XYZ patient presented in ENT OPD with complaints of fever, sore throat, and pain and on swelling. After examining, doctor confirmed the diagnosis of diphtheria. The isolation period recommended for this patient is till A, complete blood picture becomes normal, 2, consecutive negative throat and nasal swab cultures, C, negative chest radiographs, D, after completion of antibiotic course, E, 5 consecutive negative throat and nasal swab cultures.
B.
Yes, it is B.
B.
Yes, it is B. Third, a person underwent Schick test and throat culture for diphtheria. It was unrevealed that he is Schick negative but throat culture positive. He is a patient, B, carrier, C, immune, D, susceptible, not immune.
B.
No, that would be a patient. A. Fourth, 8 years old presented in OPD with complaints of fever, sore throat, and difficulty in swelling. On examination, there is membrane formation at back of throat and enlarged cervical nodes produce a bull-neck appearance. It would be A, pharyngeal diphtheria, laryngeal diphtheria, C, nasal diphtheria, D, cutaneous diphtheria, E, none.
A.
Yes, it is pharyngeal diphtheria. A. Fifth, 10-year-old child was tested for diphtheria. His throat swab was taken and Schick test was performed. Final result were that his throat culture was negative while his Schick test was strongly positive. On the basis of these results, he is A, case of diphtheria, B, immune to diphtheria, C, carrier diphtheria, D, susceptible diphtheria, and E, not a case of diphtheria. Anyone?
C.
No, that the person would basically be susceptible to diphtheria. D. C. Sixth one is XYZ patient presented in dermatology OPD with chronic tropical ulcer. On examining, the ulcer is punched in characteristics on the which is a type of diphtheria according to statement. A, pharyngeal diphtheria. B, laryngeal. C, cutaneous. D, nasal diphtheria. E, none. Anyone?
D.
No, it would be C. It's cutaneous diphtheria. Here we can see the tropical ulcer, and the hints given are the ulcer is punched out as well as earlier told. So that most probably would be giving us the cutaneous diphtheria. Seventh, patient is admitted in hospital while with the diagnosis of diphtheria. Patient facing the problem of restlessness and difficulty in breathing. On 43 day of admission, patient was expired. Which type of diphtheria is fatal? Pharyngeal, laryngeal, cutaneous, nasal diphtheria. E, not a case of diphtheria. That is
B.
B. Yes, it is B, the laryngeal diphtheria. Eighth, diphtheria is bacterial infection caused by Corynebacterium diphtheria transmitted from person to person. Which of the following age group is mostly affected by the diphtheria? A, 1 to 5 years. B, less than 6 months of age. C, greater than 65 years. D, women of reproductive age. E, women of any age.
A.
Yes, it is A, 1 to 5 years. Ninth, diphtheria vaccine consists of diphtheria toxide available in combination with produces and tetanus vaccine. Which of the following is not true about vaccine administration? A, people of all ages not need diphtheria vaccine. B, it is vaccine of choice for children 6 weeks through 6 years of age only. C, booster DRAP is given at 11 years. D, in adults, booster dose is given every 10 years. E, people of all ages do need a diphtheria vaccine.
B.
No, it's A. They have asked basically which one is not true. And I have earlier told the motto is to basically all people of all ages to need diphtheria vaccine. So the statement which is not true is the A one. Question number 10. There are multiple combinations of vaccine which are used to secure the child from 3 diseases like pertussis, tetanus, and diphtheria. Which combination is used in faint group? A, DTaP or DTP. B, DT, C, DPT. Sorry, C, D, DP, D, APT, or E, AT.
A.
Yes, it is A. That would be all. Here is the key. Thank you so much, everyone. Here is the YouTube link of my presentation. Kindly please like and subscribe the channel.